Good afternoon, everyone. My name is Brittany Starks, and I am the Communications Director for Debbie Stream Foundation. I want to thank you all for joining our webinar this afternoon. Before we begin, I'd like to take a moment to thank our sponsors for this event. Amgen, Daiichi Sankyo, and Merck are our platinum sponsors, our silver sponsor, Bristol Myers Squibb, and our bronze sponsor, Seagen. During the duration of this webinar, you can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions after each presentation as time allows. I will now introduce today's speakers. Today we have Dr. David Ilson. Unfortunately, Dr. Haejin In will not be joining us today due to an emergency, but we do have Melinda Ross with Massive Bio. First up is Dr. David Ilson. He's a medical oncologist and attending physician at Memorial Sloan Kettering Cancer Center and a professor of medicine at Weill Cornell Medical College. He's a nationally recognized authority in the treatment of gastrointestinal cancer, whose primary area of research interest involves upper gastrointestinal cancer with special focus on esophageal cancer. Much of his research has focused on the study of new agents in advanced esophageal cancer and the evaluation of novel agents in combined modality therapy programs in locally advanced disease. Dr. Ilson's other areas of clinical expertise include gastric, colorectal, esophageal, pancreatic, and other gastrointestinal cancers. Dr. Ilson also serves as a DDF Scientific and Medical Advisory Board member. Dr. Ilson, thank you so much for joining us today. I will now turn the presentation over to you.
Great, thanks so much. It's a pleasure and privilege to speak today. What I am going to cover today, because this is really the focus of interest of new clinical trials, is the recent advances in immunotherapy and targeted agents in gastroesophageal cancer. These are my disclosures. These are consultancy agreements with various pharmaceutical companies. Okay, I'm trying to advance the slides. Okay. So in the course of my talk today, I'm going to review the advancement of immunotherapy drugs, which are now part of first-line treatment in the chemotherapy management of advanced esophagogastric cancer. We're also now seeing that immunotherapy drugs are being used in the post-surgery setting in esophageal and gastroesophageal junction cancers. We'll spend time talking about novel and enhanced drugs that target the HER2 pathway, as well as other emerging targets. So I just wanted to overview briefly the nature of clinical trials. Phase 3 trials are probably the most important to get new drugs approved and new drug development. Phase 3 trials essentially compare a care standard to a new therapy. Sometimes, in some cases, the standard of care may be no treatment. So if the standard of care is no treatment and we're comparing it to a new therapy, this is the situation where sometimes patients that get assigned to the standard arm would receive a placebo because the standard of care is no treatment. Other phase 3 trials address modifying standard treatment. So that might include adding a new drug or new drugs to standard treatment to try and improve over the standard of care. Phase 3 trials, again, usually are not placebo controlled, but when they include a placebo, that usually means that the standard of care would be no treatment, no additional therapy. Now, phase 2 trials are a little different. There, it's really a single arm study where all patients will receive the novel treatment. So it's a single arm study in which all patients have access to the new therapy. And the main goal of a phase 2 trial is to see if there's response or activity for a new therapy. There are situations where phase 2 trials are randomized, and that's often when we're comparing two novel treatments. Phase 1 trials are really the early phase trials in drug development, really studying an entirely new therapy or an entirely new combination of therapies. The main focus of phase 1 trials is to first make sure that the new drug treatment or new drug combination is safe and has acceptable side effects, and we identify what the correct doses of the new drug are. Treatment effectiveness, however, in a phase 1 trial is usually not the primary endpoint. So phase 1 trials would really be a promising new drug, usually tested in a patient that's been through all the standard therapies, and oftentimes there's not another standard therapy available. And the other new development in clinical trials is contemporary trials are now directed to patients with specific biomarkers. So that is, we do genomic testing on cancers to identify very specific molecular targets which the new drugs can attack. So that's really the new development in clinical trials, is really trying to tailor the clinical trial to the specific profile and molecular genomics of the individual patient. So as part of that, in patients that have advanced gastric cancer, if there's a newly diagnosed patient, there are certain tests that are mandatory that we need to perform to identify the profile of the patient. 3 important tests that can be obtained very quickly include staining of the tissue for HER2. So about 20 to 30% of patients with esophagogastric cancer are HER2 positive, and we need to identify that with tissue testing to see whether patients are eligible for HER2 targeted drugs, including Tristism and Tristism Abduruxtican. The second important test is tissue testing for DNA mismatch repair protein deficiency. This is a critical test. About 7% of gastric cancers have mismatch repair protein deficiency, and these are patients in which immunotherapy drugs are highly effective. Actually, you could argue more effective than chemotherapy, and potentially even more effective than radiation and surgery. So it's important to test patients for this marker, and immunotherapy treatments really move to the front of the line for such patients. And then lastly, the third most important test is PD-L1 testing. This is the target for most immunotherapy drugs. And as I said earlier, immunotherapy is now approved, both nivolumab and pembrolizumab, in the first-line treatment of gastric cancer. Patients that test positive for PD-L1 have a better chance of responding to this treatment. And then certainly if we have enough tissue remaining from a biopsy, we do genomic profiling. This looks at hundreds of genes in the cancer. It may identify HER2 positive patients as well as amplification of other genes. And it may also validate this mismatch repair protein deficiency by looking at molecular tests. Now, actually, it's important to do genomic profiling because we have approval for some new drugs. If some patients have certain rare mutations, including BRAF V600E or NTRK gene fusion, these patients may be eligible for drugs that target that pathway. And now we have the advancement of blood-based genomic profiling. If we don't have enough tissue available, we can send a blood sample prior to embarking on chemotherapy or targeted treatments to identify tumor-related genes that are affected in the blood that may identify other targets for patients. So what about genomic profiling? The 2 most important subsets that we identify from genomic profiling, one is called genomically unstable. That's the most common subtype of gastric cancer. That's the group of patients that often have HER2 positive tumors, but there may be other targets, including FGFR and EGFR, that may be targetable with drugs. And then I mentioned earlier the mismatch repair protein deficient cancers, or MSI-high cancers. That's 7% of gastric cancers. These are patients who are really, really responsive to immunotherapy. And as I said, immunotherapy should really move to the front of the line to treat patients with either MSI-high or mismatch repair protein deficient cancers. So let's focus on immunotherapy. The 2 most important targets for immunotherapy, one is called Ctla4 blockade. So the reason that our immune response is inhibited in cancer is that the tumor cell can actually block activation of our immune cells, of T cells. And actually, by activating the receptor PD-1, it can actually lead to death of the T cells, of the immune cells. So what immunotherapy does is it blocks that PD-1 or PD-L1 pathway. So it allows T cells to respond and to survive and to mount an immune response. So that's how drugs like nivolumab and pembrolizumab work. They work by blocking this mechanism that shuts down the immune response. On the left, the other pathway is Ctla4. That is affected by a drug called ipilimumab. That's more involved in how the immune system presents the cancer antigens to the immune system to respond. The most important pathway, however, is the PD-1 pathway, and again, that's blocked by nivolumab and pembrolizumab, which are both approved drugs to treat advanced metastatic gastric cancer. Ipilimumab, which blocks the antigen-presenting pathway, that drug is approved for combination treatment in squamous cancers of the esophagus. So, as I said earlier, immunotherapy is now advanced to first-line treatment in esophagogastric cancer. Typically, chemotherapy is an important part of treatment in advanced or metastatic disease, and these are the chemotherapy regimens that we prefer to use. They're the most effective with the least side effects, and these include FOLFOX, capecitabine and oxaliplatin, and less commonly used FOLFIRI. These are the NCCN guideline preferred chemotherapy regimens. And I'll stress again that immunotherapy is approved to combine with first-line chemotherapy. And the FDA, I think in their wisdom, did not mandate that patients had to have PD-L1 positive cancers. As I said earlier, PD-L1 positive cancers may respond better to immunotherapy, but there is still a chance or hope of benefit for immunotherapy drugs, and they are approved to administer to all patients with newly diagnosed gastric cancer that have advanced disease. So the trial Keynote 590, this focused more on esophageal and GE junction adenocarcinomas. Pembrolizumab showed survival improvements. Average survival time was over a year, which is a new benchmark, adding immunotherapy to chemotherapy. The drug that's more used in gastric cancer is nivolumab. That's based on the trial Checkmate 649. That showed that adding nivolumab to first-line FOLFOX also achieved an average survival time of more than a year, a new benchmark. So nivolumab plus FOLFOX is a new standard of care to give to patients with newly diagnosed stage 4 gastric cancer. Pembrolizumab we would use more for esophageal and GE junction adenocarcinomas. In addition to improving survival, the response to treatment was improved, the time on therapy was improved, and now we have another approval in HER2-positive gastric cancer. Pembrolizumab showed a dramatic improvement in response to chemotherapy when combined with Herceptin, Trastuzumab, and chemotherapy in HER2-positive disease. And then lastly, in esophageal squamous cancers, we have the also approval for nivolumab to combine with chemotherapy, but also a non-chemotherapy treatment using the drug ipilimumab combined with nivolumab as an immunotherapy in squamous cancers. So these are the survival data curves. You can see that the two trials clearly indicate improved survival with the addition of immunotherapy to chemotherapy. And then in the bottom here, I've shown you the results for HER2 added to chemotherapy, the pembrolizumab added to chemotherapy in HER2-positive disease, where 75% of patients had a response to chemotherapy. This is unprecedented. So it's really now standard of care as well in a HER2-positive advanced gastric cancer to combine immunotherapy with pembrolizumab combined with Herceptin and chemotherapy in HER2-positive disease with a 75% chance of having a good response to chemotherapy. So I did mention earlier, however, that there is some dependence of the benefit on immunotherapy with PD-L1 score. Patients that have higher PD-L1 positive scores do better. This is the data for Keynote 590. Here we see outcome in patients that had CPS scores less than 10% versus greater than 10%. You can see that the greater than 10% had anything that's to the left of the midline here is a survival benefit. And you can see a better survival benefit for CPS 10% or higher compared to less than 10%. There still is a benefit, but it's more modest. Similarly, nivolumab plus chemotherapy in gastric cancer, the greatest benefit is in patients that have CPS scores greater than 5 to 10%, a clear lesser benefit when the CPS is less than 1%. So I just want to mention some of these other drugs. This is mainly from China and Asia. Pretty much all the trials of recent drugs have shown a benefit for immunotherapy combined with chemotherapy, including a drug called Pembrolizumab in esophageal cancer, a drug Sintilimab in both gastric and esophageal cancer, and a drug called Tristism in gastric cancer. So pretty much all the recent studies have shown supportive benefits for combining immunotherapy with chemotherapy. These may be drugs that may potentially enter the market as well in the West. So what's the future of immunotherapy? So here's where the new generation of clinical trials come in. There's a lot of excitement now in CAR T cells. So this is taking the patient's own white blood cells and engineering the white blood cells to fight a cancer. Usually we have to engineer the patient's white blood cells to attack a particular target on the cancer cell. And target-specific antigens include the Maj protein and the Claudin protein. We'll talk about Claudin a little bit later, but there are ongoing CAR T cell programs targeting Maj and Claudin. There were recent very exciting results for the Claudin T cell program, reporting a response in up to 60% of patients. These were patients that had resistant cancer to all previous treatments. So obviously there's a lot of interest in the CAR T cell program moving forward and directed towards Claudin. I will say, however, the only disappointing thing from these trials was that the duration of the benefit was fairly short. The biggest excitement for CAR T cell therapy is in lymphoma and blood cell cancers, where we now sometimes see very durable remissions. Right now, we are seeing activity for CAR T cells in gastric cancer, but the benefits appear to be short. So it's a work in progress. The other exciting area of new research trials is novel antibodies. Right now, we have the approved antibody Herceptin for HER2. There also is a newer antibody called Tristism Abduruxtican, which we'll talk about. But again, we're looking at novel antibodies that target these pathways. And sometimes these antibodies are hybrid. So they'll target something like PD-L1, and they may target HER2, they may target this new Claudin protein. And one of the main roles of antibodies targeting these pathways is not only to kill off the cancer cell by attacking the pathway, but the antibodies may actually recruit an immune response. So these novel antibodies may not only attack the cancer cell and target a specific antigen, but may recruit an immune response that may also hopefully fight the cancer back. And then there are novel combination strategies. So in my assessment, the most promising areas of research now are these novel antibody constructs, where the antibody is targeting an immune pathway and a target like HER2 or Claudin. And then the CAR T cell therapy, which is very early on. It's only really available now at certain centers now, and certainly your treating oncologist can see whether or not, if they're treating a patient, whether the patient would be eligible for one of these programs. So what about immunotherapy after surgery? So we now have positive results that nivolumab can be given after chemotherapy, radiation, and surgery in cancers of the esophagus and GE junction. We don't have results yet for patients that have gastric cancer that have undergone surgery and chemotherapy. But in esophageal cancer, esophageal adenocarcinoma, where patients get chemotherapy, radiation, and surgery, there were positive results for patients getting a year of nivolumab after surgery compared to no further treatment. Here we saw, it looks like a modest difference, but actually the time disease-free survival was doubled with the use of nivolumab. So many patients recurred within the first year. That was stretched out to 2 years. So we improved the time to recurrence to 2 years. And this very significant improvement in disease-free survival, a doubling, will almost certainly translate into a survival benefit. So positive results for this trial in esophageal and GE junction adenocarcinomas in patients getting chemotherapy, radiation, and surgery. This is the new standard of care. And benefits were seen in adenocarcinoma and squamous cancers, were seen in patients with lymph node positive and negative disease at surgery. And there was, again, as I've said over and over, PD-L1 positive patients tend to benefit more from immunotherapy. The greatest benefit was in patients that had PD-L1 positive cancers. There was a lesser benefit, but still a trend towards a benefit in the low PD-L1 patients. So what about gastric cancer immunotherapy trials? So there are two key trials that were recently completed in the West. One is Keynote 585. So this was a gastric cancer trial in which everybody got chemotherapy before and after surgery, and half of the patients got the addition of Pembrolizumab and half didn't. So this trial is completed, and we want to see whether adding Pembrolizumab to surgery and chemotherapy in operable gastric cancer makes a difference. The other important trial, I think this trial is probably even more important because we typically use the FLOT regimen. That's a 3-drug chemotherapy regimen added to surgery. So this trial is looking at gastric cancer surgery plus standard chemotherapy with or without the immunotherapy drug durvalumab. So we'll await the results to see whether adding either durvalumab or pembrolizumab to surgery and chemotherapy improves outcome compared to surgery and chemotherapy alone. So I want to just focus again a little bit on MSI high cancers. These are those mismatch repair protein deficient cancers or MSI high cancers. It's about 7% of gastric cancers. If you have a localized cancer, if it's localized and you're thinking about doing surgery with or without chemotherapy, if you have an MSI high cancer, this is survival. So your survival, both your disease-free and overall survival, are much better if you have an MSI high cancer as opposed to a microsatellite stable cancer. So MSI high cancers have a better prognosis, and some of these patients were even treated with surgery alone. So we're now routinely testing not only patients with metastatic or stage 4 gastric cancer for mismatch repair protein deficiency or MSI high status, we are now also testing localized patients because these patients may have a better outlook even with surgery alone. The other issue in MSI high localized gastric cancer is whether you should give chemotherapy in combination with surgery. So these are results in this part of the figure here. I've shown survival in patients. The top two curves are the MSI high gastric cancer patients. The patients that had the best survival in this series had MSI high gastric cancers that only got surgery, that didn't get chemotherapy. The MSI high surgery patients that got surgery and chemotherapy had a trend to do worse. So you can see why it's important to document MSI status when you're going for surgery for gastric cancer. Perhaps you should get surgery alone, and perhaps chemotherapy has either no benefit or may have a negative impact. We think that's the case because MSI high cancers often have a very good immune response to the cancer, and chemotherapy may not add to that. It may actually be a negative. So I just want to mention a really provocative trial from France. MSI high gastric cancers were identified in a French trial. They treated 32 patients with MSI high gastric cancers that were localized and were potentially candidates for surgery. So as I told you, MSI high cancers really respond dramatically to immunotherapy. So this was a trial in France where they got immunotherapy as their preoperative treatment. They didn't get chemotherapy, they didn't get radiation. They got a combination of 2 immunotherapy drugs, nivolumab and ipilimumab, over 6 weeks. So 6 weeks of treatment, and then they went to surgery. So what I want to highlight here is in the green here, of the 29 patients went to surgery, and after 6 weeks of immunotherapy, 60% had no cancer found at surgery, indicating a dramatic response. Another 20% were near complete responses to chemotherapy. So 80% of patients with MSI high gastric cancer, if they got immunotherapy up front, 60 to 80% had little or no cancer remaining at surgery. So why is that of interest? Well, what if you continue the immunotherapy? Maybe you don't even need the surgery. So this is now stirring a debate in MSI high esophagogastric cancers. Since we're seeing such dramatic responses to immunotherapy in patients that maybe it's a big surgery, it may have negative effects, should we consider immunotherapy as a preoperative treatment followed by surgery, or immunotherapy by itself if it looks like patients have a complete response. So these are very provocative data, and this discussion now in MSI-high locally advanced gastric cancer, should they get surgery alone? Should they get immunotherapy alone? Should they get immunotherapy followed by surgery? This is really an exciting new debate in localized gastric cancer. Right now, we don't have a trial in the United States focusing on these patients, but the planned and proposed trial is probably going to include immunotherapy as an upfront treatment. And I would argue if patients achieve what looks like a complete response, potentially observing patients without surgery. And this just looks at the survival. Look at the survival curve in here. It's like 95%. So this is a lot better than the slides I showed you earlier with lower survival with surgery and chemotherapy. So we mentioned this earlier. I talked about the Keynote 585 trials and the FLOT trial. So we're awaiting results in all patients for durvalumab and pembrolizumab. But these patients treated mostly MSI negative patients. So we're not going to probably be able to conclude much about what we can do with MSI high patients. These trials looked at immunotherapy in microsatellite stable cancers. So I just wanted to talk a little bit about HER2. This is the other very active area of research. HER2, I told you every patient with advanced gastric cancer needs to have HER2 testing. If you're HER2 positive, you should get Herceptin or Trastuzumab combined with chemotherapy. Adding Trastuzumab to chemotherapy improves survival compared to chemotherapy alone. So now in stage 4 cancer, we add Pembrolizumab to Herceptin and chemotherapy. Why is that? Because we saw a dramatic improvement in response. This is called a waterfall plot, and you can see that many more patients that got Pembrolizumab had response compared to Herceptin and chemotherapy alone. 75% compared to 50%. So if you have a HER2 positive stage 4 gastric cancer, we now give Pembrolizumab, Herceptin, and chemotherapy. So what about second line treatment? Let's say you've gotten your Pembrolizumab, Herceptin, and chemotherapy and it's not working any longer. Older drugs like TDM1, Trastuzumab Emtansine, was no better than chemotherapy, conventional chemotherapy. So a drug active in breast cancer, TDM1, did not work in gastric cancer. Another issue is if you get Herceptin as part of your first treatment, should you continue it into future treatments? This was a Japanese trial that showed no survival benefit for continuing the Herceptin into the next line of chemotherapy. So the new approved drug for HER2 is Tristisum Abduruxtican. This was approved by the FDA over a year ago. This is for patients that got initial Herceptin and it isn't working anymore. Now we have this drug, Tristisum Abduruxtican, as an option for second or third line treatment in patients that are HER2 positive. Tristisum Abduruxtican is a very interesting drug. It takes the antibody Herceptin, so this is the antibody Herceptin, but it links to the Herceptin a chemotherapy drug. So what happens is the Herceptin molecule links up to the tumor cell, and then it delivers this chemotherapy drug to the tumor cell. And it's a very potent way of delivering chemotherapy to a HER2 positive cancer. So the trial that got approval for this was a trial from Japan called Destiny Gastric 01. These were patients that had HER2 positive gastric cancers, had received previous Herceptin, and the tumor was progressing on it. And patients were assigned to get treatment with Trastuzum Abduruxtican or the physician's choice of conventional chemotherapy, which was usually either paclitaxel, docetaxel, or irinotecan. And you can see that Trastuzum Abduruxtican was better than chemotherapy. The survival was better, the time on chemotherapy was better, and 40% of patients responded compared to only 14% with conventional chemotherapy. So based on this trial, Trastuzum Abduruxtican is now approved in the second or third line treatment of patients with HER2 positive gastric cancer. I'm going to skip this. So because this trial was done in Japan, a similar trial was conducted in the West, in the US, looking at Western patients that had HER2 positive gastric cancer that had progressed on first line Herceptin. And indeed, the Western trial treated nearly 80 patients. And very similar to the Japanese trial, there was a 40% response to Tristism Abduruxtican. So this drug was equally effective in Western patients. So just validating that this drug works just as well in Western patients as it does in patients treated in Asia and Japan. I just want to mention 2 ongoing trials of this drug. There is not a lot of interest now in looking at Tristism Abduruxtican as the first treatment for metastatic gastric cancer. And there are trials ongoing combining this drug with immunotherapy, combining it with chemotherapy drugs, and they're ongoing. The other trial is second line. Right now we have options in second line treatment of gastric cancer. Certainly Tristism Abduruxtican is the key option in HER2 positive disease. But we also have the option of a drug combination called paclitaxel ramucirumab. So the one trial is looking at novel combinations first line with Tristism Abduruxtican, and the other trial is comparing Tristism Abduruxtican versus conventional second line chemotherapy. I just want to mention a few other drugs that are in development. One of the most important and promising is tucatinib. This is an oral HER2 drug. And we'll talk about the design of the tucatinib trial shortly. Marjotuximab, this is another promising HER2 targeted antibody, very active in gastric cancer. When you combine it with pembrolizumab, we saw a 50% response in a trial. However, the company has backtracked a little bit. They were trying to develop this drug first line combined with chemotherapy, but right now the development of marjotuximab is on hold. And then the other drug I want to mention, so tucatinib in active trials, is Xanadatimab. Xanadatimab is another exciting HER2 drug. This is also being looked at in first line in combination with chemotherapy with very promising results. So Mountaineer is the trial in second line HER2 positive patients adding tucatinib to treatment. Tucatinib is what's called a tyrosine kinase inhibitor. The HER2 molecule essentially crosses the cell membrane of the cell. The HER2 receptor is activated typically by Herceptin, and the business end of the HER2 receptor is the tyrosine kinase. That's the driver that starts signaling in the cell. Tucatinib is a tyrosine kinase inhibitor of HER2. So the Mountaineer trial looks at patients that cancer has progressed on initial treatment with Herceptin, and it's now looking at adding tucatinib and trastuzumab to second-line chemotherapy. So second-line chemotherapy is paclitaxel ramucirumab. This trial is looking at paclitaxel ramucirumab with or without the addition of tucatinib and trastuzumab in a later line treatment. So this is an exciting trial that's ongoing in the US. Right now, this is probably the only access we can get to tucatinib. This drug is approved in breast cancer and looks very promising. Marjotuximab, I talked about earlier. This is a novel Herceptin-like molecule. It's very similar to trastuzumab or Herceptin, except it's engineered to give a better immune response. Mahogany was a trial that was moving marjotuximab to first-line treatment, combining marjotuximab with chemotherapy and immunotherapy. And there was a recently reported trial of marjotuximab plus immunotherapy, where they achieved a 50% response. However, 50% was not as good as the 75% response that was seen with pembrolizumab. So the company has put this development program on hold. It's really a shame. This is a very active drug. It's approved in breast cancer. Hopefully, we will see some movement in the future. If the company is not going to develop this drug in first line, they may look at it in later lines of HER2 positive disease. Xanadatumab is the other exciting new drug. This is a very similar drug to Herceptin. Again, it's like trastuzumab. It's a monoclonal antibody. But Herceptin or trastuzumab only attacks one part of the HER2 molecule. Xanadatumab is engineered to attack two parts of the HER2 molecule. And this drug by itself has substantial activity, even by itself, in HER2 positive cancers, including gastric cancer. About a 30% response in gastric cancer, and very striking responses when you combine Xanadatumab with chemotherapy. A recent first-line trial untreated patients with HER2-positive gastric cancer, Xanadatumab plus chemotherapy had a 75% response rate, just like the Pembrolizumab study. So these are the data for single agent Xanadatumab. Again, it's about a 40% response. This was in people that had gotten a lot of previous chemotherapy. And when you combine Xanadatumab with either Taxol or capecitabine, the response rate was 60%. So this drug has activity by itself and in combination with chemotherapy later. And these are the data for Xanadatumab plus chemotherapy given as the initial treatment, a 75% response rate. So I think this drug is a contender as well for studying in first-line treatment. So I just want to move on to FGFR. FGFR is another pathway that can be targeted in gastric cancer. It's like the HER2 molecule. It's a receptor on the cancer. If you give a drug that blocks the receptor, it may shut down tumor growth. And the other thing, if you block the receptor and have an antibody, it may generate an immune response. So Marjotuximab is an antibody that was developed that attacks the FGFR receptor. And in patients that had the target present, it had a response rate of about 18%. So the drug, even by itself, was active in FGFR cancers. So recently, there was a randomized phase 2 trial adding Marjotuximab to first-line chemotherapy with FOLFOX. Now, FGFR gene amplification is only found in about 5% of cancers. However, if you just test the tissue, if you stain the tissue to see if FGFR is present, 30% of patients test positive. So this is a significant subset of patients with advanced gastric cancer. 30% of newly diagnosed gastric cancer patients may be candidates for FGFR drugs. So this trial looked at standard FOLFOX chemotherapy with or without Marjotuximab in the 30% of patients that screened positive for FGFR positive expression. And this was a positive trial. FGFR Marjotuximab improved time on treatment and survival compared to chemotherapy alone. These are updated survival results. The stronger the staining for the FGFR, the greater the survival benefit. And response to chemotherapy was also improved by about 15%. So this drug is now in first-line development. The standard arm is FOLFOX plus immunotherapy, and then half of the patients get Marjotuximab added to treatment, and half just get FOLFOX plus immunotherapy. You would be eligible for this trial if you're in the 30% of patients that test positive for overexpression of the FGFR receptor. Then I want to end my talk with Claudin 18.2. We are going to hear results from drugs targeting this pathway in the next few months. Claudin 18.2 is a protein very commonly present in most gastric cancers, 80 to 90%. And we developed a drug called zolbetuximab, which binds to this protein and may generate an immune response. So there were very promising early data when we combined zolbetuximab in patients that have this protein present. You can see rather substantial improvements in survival for combining zolbetuximab to chemotherapy compared to chemotherapy alone. So Claudin is another promising target. We have 2 completed trials now. FOLFOX plus zolbetuximab, capecitabine oxaliplatin plus zolbetuximab. If this trial improves survival, this may emerge as another drug that may be an option in first-line treatment. So I think I've given you an overview of advances in gastric cancer immunotherapy and targeted agents. Immunotherapy is now part of standard first-line treatment in stage 4 gastric cancer. Pembrolizumab is approved not only in adenocarcinoma of the esophagus, but Pembrolizumab is approved to combine with chemotherapy in HER2-positive disease. For gastric cancer, we also have approval of nivolumab combined with chemotherapy. We now have novel and enhanced HER2-targeted therapies. In addition to Herceptin first line, we now have Tristism Abduruxtican, which is called Enhertu, improved as a second-line treatment for HER2-positive disease. And we have promise for drugs like Xanadatumab, Marjotuximab, and Tucatinib. We now have approval of adjuvant immunotherapy for esophageal and G-junction adenocarcinomas, and other promising emerging targets that are involved in trials include Marjotuximab targeting the FGFR receptor and Zolbetuximab, which targets Claudin 18.2. And this lecture was really to introduce you to the promising targets and research directions, and always discuss with your treating oncologist, am I eligible for a clinical trial? Is there something better than we can do with standard of care? Thanks so much.
Thank you so much, Dr. Ilson. We did have 2 questions that came in. The first one is, I'm a newly diagnosed patient. How do I know if a clinical trial is right for me?
Yeah, I think the new standard of care, if you have metastatic cancer, the new standard of care is FOLFOX plus nivolumab. That's a pretty effective combination. If you have a HER2 positive cancer, then you would get pembrolizumab, Herceptin, and chemotherapy. So you would really want to see, as a newly diagnosed patient, whether there is a trial that offers something better or something new. So right now, the drugs that are in first-line development would include Marjotuximab. Marjotuximab is being added to immunotherapy and FOLFOX in first line if you're a candidate. And then the HER2 trial, right now, it may be on hold now, is the Xanadatumab trials being looked at in first line, but I believe they may be on hold right now. If you're a surgical candidate, then you need to have your tissue tested for MSI high. If you're a surgical candidate, typically we would give chemotherapy before and after surgery. Right now, immunotherapy and surgery for gastric cancer is not approved yet. So you need to talk to your oncologist. You need to have the appropriate tissue testing, which is HER2, PD-L1, and the mismatch repair MSI. Make sure you got your biomarkers tested. Make sure that your oncologist either sends your blood or your tissue for genomic profiling, and then review whether any clinical trials and initial treatment are appropriate. But knowing that we have a fairly effective standard first-line treatment if clinical trials are not an option.
Okay, thank you so much. We have another question that came in. What are your thoughts on taking immunotherapy for PD-L1, CPS1 in gastric cancer patients?
Yeah, well, I try to be the patient advocate here. So the FDA in the United States approved nivolumab for every patient, regardless of PD-L1 status. I think that was a really good move because it really empowers patients to get this drug. Arguably, the benefits are less. If your PD-L1 is less than 1 to 5%, your likelihood of benefiting from nivolumab or pembrolizumab is much lower, but it's not zero. We know that from the nivolumab trials, your response to chemotherapy is enhanced with nivolumab added to chemotherapy compared to chemotherapy alone. The other issue in somebody who tests negative or low for PD-L1 is, remember, that's based on one biopsy. What if a different biopsy or a biopsy of a metastasis showed positive testing? So my practice, the FDA approved nivolumab for all patients. Yes, we know if you're PD-L1 positive, you do have a better chance of responding to immunotherapy. But I give patients the benefit of the doubt, and I treat all my patients, regardless of PD-L1 status, with immunotherapy. Because now, remember, immunotherapy now is only given as part of first-line treatment. When you get to second or third line treatment, immunotherapy is no longer available. So you really have the option and potential to get this drug as part of your initial treatment. This is not something you need to discuss with your doctor. Some of my colleagues will not give nivolumab or pembrolizumab if the CPS PD-L1 score is 0. I treat all patients with the knowledge that the benefit is likely to be less, but we can't say for sure that there is no benefit.
Thank you. And one last question came in. Is immunotherapy good for GIST?
Right now, immunotherapy, GIST is a completely different animal. I'm not a GIST expert. We have a lot of effective treatments for GIST, including imatinib, sunitinib, regorafenib, many drugs. Right now, immunotherapy has not shown promise in GIST tumors to date. And there's really no connection between GIST tumors and gastric cancer. It's a sarcoma. It's a very different cancer. And that's someone that you would be treated by a sarcoma expert, not a gastric cancer medical oncologist.
Thank you so much, Dr. Ilson. We appreciate your presentation. We're next gonna move on to our next presenter, and we have great news.
I'm going to sign off. So thanks very much, everyone, and have a great day, and good luck with all your treatment and care. Best of luck.
Thank you so much, Dr. Ilson.
Bye-bye.
Great news, everyone. We have Dr. Haejin In to join us today. She will be presenting on healthcare disparities and equity in gastric cancer. Just to tell you a little bit about Dr. In, she is a gastrointestinal surgical oncologist at Rutgers Cancer Institute of New Jersey, and she specializes in upper gastrointestinal cancers. Dr. In is also a cancer health services researcher and an associate director of diversity, equity, and inclusion for the Cancer Institute. And today we're so happy that she could join us. Dr. In, I will go ahead and turn the presentation over to you. I'm going to make you a presenter. And let me know.
Thank you. My apologies. I ran from the operating room, and so I still have my surgical clothing on. So to hi to everybody, let me see if I can, let's see.
Yep, we can see your screen now. Perfect.
You can see my screen now. Okay. And if I blow this up, you can see my screen, the presentation mode?
Yes, ma'am, we can see it.
Wonderful. All right. Okay, so let me minimize myself because I'm in my own way right now. Okay, there we go. All right, so hello to everybody. My name is Haejin In, and I'm a surgical oncologist. I specialize in gastric cancer, both in my clinical practice, so I'm an active surgeon who deals with gastric cancer, and I'm also a researcher who does gastric cancer as well. And my my interest in gastric cancer really stems from the fact that, you know, with gastric cancer, we got to find it early to really make an impact. And if we can find these gastric cancers earlier and treat them appropriately, gastric cancer can do very well. And you know, you can do very well from gastric cancer. And so I research, you know, the disparities that happen with gastric cancer, meaning that some populations don't get the same treatment as other people, as well as I look at early detection for gastric cancer. So how do we improve the way we find gastric cancer so that it happens earlier? Today, I'm going to focus on the disparities part of my research, and I'm going to keep it kind of on the simple side. I know Dr. Ilson's talk was very dense. Mine is a little bit less dense. Hopefully, it'll be a little bit more, it'll be entertaining. So the big question that I was posed is, are certain people at greater risk for dying for gastric cancer? And this is a report by the AACR, which is the big academic research group that looks at cancer and how to treat it. And they found in their study that indeed there are a lot of disparities, so especially by race in America. So if you're an African American, if you're a Hispanic, or if you're an Asian or Pacific Islander, your incidence rate and chances of dying from gastric cancer is nearly double of the white population. And that makes the stomach cancer the #1 to #2 disparate cancer in the United States, because you're twice as likely to die from stomach cancer if you fall into one of these racial populations. And so gastric cancer is a very problematic cancer in terms of disparities. One of the reasons why we have the disparities and the reason why it's not being addressed more quickly is that, you know, when you start to look at what gets funded and what people think about, it's typically based on what the majority of the population deal with. And because of that, you know, because our population is about 60% white, when you kind of lump it all together, gastric cancer doesn't seem to be a very priority cancer, shall we say. It doesn't come up as a top 10 cancer, for example. But if you look at it within the racial and ethnic groups, it actually is a top 10 cancer for Blacks, Asians, and Hispanics, and for for a couple of the other ethnicities, such as Koreans, Japanese, Chinese, Vietnamese. It's actually a top 5 cancer for these populations. So if you look here on this figure, you can see that compared to whites, Blacks have a doubling of incidence, so that's the first, the lighter blue, and nearly a doubling of mortality from gastric cancer. If you look at Hispanics, you'll see the same pattern where Mexicans and Puerto Ricans have a doubling of both incidence and mortality from gastric cancer. And for Asians, this is even worse, where now they're dealing with a nearly tenfold difference in incidence. So then why are some people at greater risk for stomach cancer? One of the first things that I think we have to start with is understanding why we get gastric cancer a lot of times and what those pathways are. And there's a bacteria called Helicobacter pylori that was discovered only about 30, 40 years ago. That is a bacteria that is now associated with nearly 90% of the gastric cancer that we diagnose. And so this bacteria colonizes, so you get the infection when you're very early, when you're very young. Studies have shown that you get the Helicobacter pylori probably before the age of 5. And then your stomach undergoes changes because of the bacteria as it lives in the mucosa of the stomach. And it undergoes these changes from normal gastric mucosa to chronic gastritis, atrophic gastritis, intestinal metaplasia, turning into now closer to cancer where it's very dysplastic, and then finally turning into gastric cancer. And because of this, the WHO has now classified this as a type 1 carcinogen. And so Helicobacter pylori is something that we have to think about. When you look at the overall risk factors for gastric cancer, you can see that there's a lot of things that have been identified. But in particular, I wanted to point out things that are on the right side, where you can see that, for example, there's a difference in gender, where males are 3 times more likely to get cancer. There's difference in socioeconomic status, where people who have low socioeconomic status as well as lower education levels have a much larger risk of gastric cancer. And so that's really where the disparities are starting to come in, and that's that's where you're starting to see like differences. Why just because you're not as well educated, should you really be not able to survive from gastric cancer as well? And, when we logically think about it, well, no, that's not fair, right? And that's what disparities really is. So when we look at disparities, disparities really is a compilation of all of the negative things that can affect a person. That is not just about somebody's cancer biology. It's about all of those things that affect us and affect our health. For example, are you living in poverty? Are you living in poor housing? What's your food access like? What's your neighborhood like? Is there any racism involved? And so the framework that we use when we think about disparities is, we put that all together and we start to dismantle what are the factors that we should try to address. If somebody has somebody has a cancer that biologically acts worse, then you sort of understand it and you try to treat it, and you try to figure out how to correct that or make it better by trying to figure out a different drug. Well, if you find that somebody is getting worse outcomes because of the neighborhood that they live in, or because of So for example, like the type of foods that they're eating, then the intervention needs to be different. Discovering more drugs is not going to change that. You actually have to change their environment, change what's happening to them, change what they're eating. So putting that all together is really where our disparities work is. And to share this, now this is not for gastric cancer, but this is for overall, when we think about, you know, what the impact of all of these social determinants of health is what we talk about, where it's the other outside effects. This is actually, you know, one of those things that really kind of hones it in, where you can see that by the difference in income level. So down here in the x-axis is, you know, the median income for the household. And then the y-axis is when the median survival, so median death, expected age at death. So if you can see that the poorest population in the United States, their average life expectancy for males is about 75 years old, and for females, it's about 80 years old. While as if you're living in the highest economic status, you'll see that the median, you know, expected life is around 85 for males and nearly 90 for females, which is about a 15-year difference depending on what kind of income you have. Similarly, you can also see that there's a very large difference in life expectancy by what neighborhood you live in. So this is a town in America, where you can see that in these neighborhoods that are very dark, in these black colored neighborhoods, the life expectancy is only about 60 to 70 years old if you live in these neighborhoods, compared to these lighter areas where the life expectancy is 80 to 90 years old. Once again, nearly a 10-year difference, just depending on what kind of neighborhood you're living in. So our group has been looking at this for a little while now, and this is a study that also talks about how certain populations are not getting treated for gastric cancer in the same way. And so this study was to try to understand if Black patients versus white patients were getting differences in how they were being treated. We focused on surgery for this one, and we found that Black patients were less likely to get surgery for gastric cancer compared to white. And if you look at what really drives the survival between people who do well and people who don't do well, now this is of course for non-metastatic gastric cancer, so between stage 1 and stage 2, the difference in survival was, as you can see in red here, you know, these are all of the different factors that kind of, you know, that weigh in on whether or not you do well between Blacks and whites. And the fact that they weren't getting surgery was the biggest driver of why they weren't doing well in this study. Similarly, there was another study that showed that African Americans and Hispanic patients were less likely to get optimal cancer care. So as most of this audience probably knows, for gastric cancer, it's a combination of chemotherapy and surgery as long as you're in a surgical stage. And additionally, they were also less likely to get neoadjuvant chemotherapy, so chemotherapy up front, which, as Dr. Ilson just explained, when you're in a surgical stage, that we know that does better. And so these populations were getting less optimal care. One of the other, you know, big differences for gastric cancer are populations that have immigrated from other places. So this is this first figure here is the United States. Now, once again, one of the reasons why we don't think so hard about it is that stomach cancer, if you look at the ranking of what is a very common cancer, if you look in the United States, stomach cancer really is ranked only around 15th after all of these other cancers. However, if you look at the world, gastric cancer is actually very common, and you can see here to the I guess your screen right Here you can see that around the world, stomach cancer actually ranks 5th. And there's more than 1 million cases a year that get diagnosed. And so very common cancer worldwide, not so common in the United States. So what does that mean? So once again, just to drive home the point, this is per 100,000 how common it is, so incidence rate. It's 4 per 100,000 in the United States. In countries, in the East Asian countries, you can see that there's nearly 10 times the rate for Korea, Japan, China, Vietnam, and Mongolia. In East European countries, and including places like Turkey and Iran and Russia, you can see once again they have nearly a 3 to 4 times risk. And in South American country as well as Central American countries, if you're from there, especially the western side of South America, your rate once again is very, very high, and you're at higher risk. And so if you put all of these together, and we know that so many people immigrate to the United States, if you're an immigrant from these countries, your risk of gastric cancer is going to be extremely high. And we also know that it also depends a bit on immigration. So what generation of immigration are you? So this is a study that compared the rates between first generation, so people who came over after being born in a different country, compared to people who were born here. Native Chinese indicates that that's a person who was born outside the US. Chinese American means that they were born in the United States but are of Chinese ethnicity. And you can see that these two lines completely are separated, with the first generation having much higher rates of gastric cancer and the second generation having much lower. And you can see that for Koreans, this is the same, and for Japanese as well, that there's a split in how often or how risky you are depending on immigration generation. So, you know, I also, because this was a talk about clinical trials, I also wanted to touch upon disparities in clinical trials. Now, I don't think I have to explain so much to this group, but usually we first want to talk about why is it so important to participate in clinical trials. Well, participation is critical to accurately determine, you know, how well a drug works, its efficacy, as well as toxicities of new treatments. But we also know that diversity is very important, especially when you're dealing with cancers that have a high burden in racial or ethnic minorities, like gastric cancer. These types of clinical trials really enables us to understand how ancestry-related differences in cancer biology, disease biomarkers, or treatment responses are by looking at different populations, and ensures that, you know, newly approved cancer agents can be safely used in the real-world population. This was a study that looked at 93 clinical trials, and they had, and that basically is greater than 5,000 participants, and it looked at the ratio of, so basically this study was trying to look at how representative is a clinical trial of the population that they're serving. And you can see here that for the white population, they were overrepresented in clinical trials, meaning that there was more white patients than there were the population distribution of the different races. While as all of the other races, all of the other race ethnicities had a very, very low representation in the clinical trials. So, you know, that to drive home the point, what that means is that the clinical trials are happening on white populations and can be used on white populations, but for all of the other race ethnicities, you don't know for sure whether or not it's going to work for you and how well it's going to work. So once again, race and ethnic minorities participating in clinical trials is persistently lower, only 15 to 20%, while as we know that our minority population in the United States is 36%. And because of this, fewer than 20% of all therapeutics included in the data have information about side effects in other populations. For this study, it was among Black populations. So what are the barriers? Why are minorities having more trouble being on clinical trials? Well, first is an individual level barrier. So sometimes people are just not aware of why you should be going into a clinical trial or what's the importance of it. There's also some mistrust of the healthcare system. Historically, for example, with the Black population, there have been atrocities to that population for experimentations, and so there's an inherent mistrust. There's financial barriers, which I'll talk about a little bit more, as well as things like health literacy, where if you don't understand what's going on, it's very hard to think that you can enroll in such a thing. This is a study that looked at how much of financial toxicity, so how much of a financial burden it might be to undergo a clinical trial. They surveyed 213 patients undergoing phase 1 clinical trials, and approximately 60% of the patients reported unanticipated medical and non-medical expenses. And there was worse financial toxicity in persons who had yearly household income of less than $60,000, as well as those living more than 100 miles away. And non-white and Hispanic patients were 2.5 times more likely to report that they had high or anticipated medical costs. There's also barriers on the provider level, so the doctor and the nurses that enroll people in the clinical trial, where sometimes there are going to be situations where they too don't know much about the clinical trials, and so if your doctor doesn't know about clinical trials, it's very hard to enroll you in a clinical trial. There is implicit bias, and I'll go to that in a little bit. There's sometimes lack of staff to serve populations, and so to be able to bring them in properly, and lack of cultural competence and appropriate communication skills are all factors that make it difficult to enroll minority participants a lot of times. Similarly, there's also systems barriers. So sometimes you go to an institution, and if they don't have clinical trials, well, you can't enroll in them. Also, once again, sometimes it gets very complex, and so enrolling is very difficult. There's also time constraints, and patients sometimes just can't enroll because they're not in the eligibility criteria, and such. So let me introduce this last study, which I wanted to introduce because I think it puts together all of these physician barriers, as provider barriers, as well as systems barriers quite well together. This was a study that was conducted in 5 different cancer centers. They did 91 interviews of stakeholders where it was a combination of the physicians that treated, the referring physicians that treated them, as well as nurses and heads of cancer centers. And so they asked a bunch of questions, but the 2 big questions, the important questions, were: what has your general experience referring racial and ethnic minorities to cancer clinical trials? And what factors do you take into account when you're referring these minorities to clinical trials? And so this study was about provider bias, and they were able to put together the 5 big themes that providers were talking about. The first theme was that these providers felt that interactions with minorities were perceived to be challenging. The second was that providers thought that they thought that minorities were not perceived to be ideal candidates. Clinic-based barriers and negative perceptions led to providers withholding clinical trial opportunities. And then tailoring to minority patients means that you're supposed to address misconceptions, is how providers thought about it. And then some providers thought that race was irrelevant. So why do you need to address it or talk about it? Going more into it, so the first one, minorities, interactions were perceived to be challenging. So let me give you some quotes, direct quotes from what providers were saying. African Americans, I think, have less knowledge. We take a little bit more time to explain it to African Americans. They have a lot of questions. Or if somebody can't communicate well, how am I sure they're not really sick from medication? If they get sick in the middle of the night, would I be able to take care of them if I didn't speak their language or understand them culturally? Another physician said, this is going to be a lot of work. If they can't pay it back and I'm going to get yelled at by somebody in the hospital, people sort of say it's easier just to ignore that group and give them standard stuff, because then no one gets in trouble and no one has to be crazy. The second theme was that they were perceived not to be ideal candidates. One person said, it's a compliance issue. Is this the right patient for this trial, or are we going to get meaningful information? If we're not going to meet in the clinic on a routine basis or follow complicated drug or medication instructions. Somebody said, physician bias is huge. Physicians don't always, but sometimes they do, in terms of number of visits, intensity of visits, how much monitoring they will have to do at home, how much support will they have at home. Well, he lives by himself. How is he going to do all this? I don't think it's worth asking him to take it on. It would be too much for him. And all that judgment can be made when, in fact, this person could be perfectly capable of doing it and would do a fine job, but never had an opportunity because this particular study may not have been presented to them. This was actually a clinical trial personnel, so somebody who enrolls patients, who expressed how they were thought it was a shame that the physicians didn't even offer it to them. And then, somebody commented, I see a degree of altruism more in Caucasian women than I do in African American women, as a way to say, oh, I don't think they're going to do it. Then there was another theme where they thought clinic-based barriers and negative perceptions led to providers withholding clinical trial opportunities. Somebody said, to get them to understand requires a lot of groundwork and a lot of education. When you're pushed to see 20 patients in a day, well, that's overriding pressure, and clinical trials will fall by the wayside. Somebody said, language was clearly a barrier. I wasn't going to take the time to get a translator to go and spend 30 minutes. It's a hard concept for me to get through a translator about randomization, placebo. A lot of the physicians thought that tailoring to minority patients means you had to address misconceptions. So they said, well, I try when I'm speaking with an African American patient to be very aware of history of abuses that have taken place in this country. I want to be very clear with my African American patients about why it might be of interest to them. I try to address their misconceptions. I do try to address it. I concentrate on making eye contacts. I've desperately tried not to cross my arms. You need to be transparent to the group to say it's not a negative thing, meaning we're not recruiting all of your samples to plant your DNA at the crime scene or some crazy ridiculousness. But I think based on what's happened in medicine, you need to clear the air and be upfront about it. The fifth theme was that a lot of providers thought that race was irrelevant. I don't view the recruitment of African American patients any differently than I do any of my patients. You have to personalize, individualize the therapy according to the patient. What I do here is almost colorblind. I do think there's an economical educational issue which transcends the minority issue. Those of low education, low socioeconomic status, they're less trusting of being placed on a clinical trial. Basically owing it just to lower socioeconomic, being poor rather than anything related to race. So they concluded that healthcare and research professionals and associate minorities with certain negative stereotypes, such as being non-compliant to clinical trial activities, and that potentially leads to a differential patient referral into the clinical trials based on race ethnicity. And then racism is expressed in multiple forms: stereotypes, prejudice, discrimination. Endorsing a endorsing a colorblind strategy in the hospitals and clinics unfortunately negatively affects communication in racially discordant professional and patient interactions. So you're supposed to be acknowledging the color, not ignoring it. And race-neutral perspectives do not allow for the allocation of research resources, specifically to recruit minorities. If you know that you have a large population of people who need extra resources, if you don't understand that that group needs it, then it's hard to give them more resources. So what do we have to combat all of this? Well, interestingly, COVID had a lot, and still does have a lot of negative side effects that have been happening. But interestingly, we learned some things thanks to COVID, because the clinical trials world had to change how they did things, because we were all the patients and all of us were kind of stuck at home, right? And so one of the things we learned is that consenting remotely by electronic means really helps in being able to let people participate in a clinical trial. The other thing that they learned was that using a laboratory, any laboratory, instead of having to always go to the institution where you got enrolled in the clinical trial, also helped. Because the patients could go somewhere closer to home instead of having to drive back all the time. Permitting telehealth instead of having to always come in to meet your doctor to tell them about how things are going. Doing telehealth instead has also been able to improve the accessibility of clinical trials. Having clinical trials available in the network sites. So as you know, most of the cancer centers, including the one that I'm in, we have the main cancer center, but then we also have either our hubs or our affiliated sites where they're all cancer centers, but it's not the main location. And so being able to put the clinical trials also to those locations so that you can enroll in a location that's closer to home also improves the access and hence reduces disparities. For the drugs, do you always have to come into the main, come back into the clinic? Can we send instead your drugs to your home instead, is another tactic, as well as just making the clinical trials more available, including places like rural areas and underserved areas. So these are all things that we've learned that improve upon how we can make clinical trials more accessible, as well as reduce disparities. So in summary, very large disparities do exist for gastric cancer mortality, and we really do need to do more research to really understand and start to tackle these disparities. And individual provider and system biases need to be addressed to provide equitable care, including the enrollment of clinical trials. So thank you, and I'm happy to take any questions.
Thank you so much, Dr. In. Your presentation was amazing. Very much so excellent. And I'm going to take some questions from the audience now. Just want to make sure. Can you see my screen now?
I can. Thank you.
Okay, perfect. So a question that came in is, knowing all that we've learned today about the disparities in healthcare from either a patient, physician, or healthcare provider perspective, what are some things you think we can do to close the gap?
Absolutely. So I think that there has to be a lot of effort. The biggest thing that I think we need to do is we have to acknowledge and understand that there are disparities. I think that if we turn a blind eye to it, if we think that, being colorblind is okay, then you can't tackle the problem. So I think that first and foremost, we need to acknowledge that there is a problem and that there are patients that just based on their race, ethnicity, that there are differences in how they do. Once we acknowledge that, then I think that there will be a much greater surge of people who are interested in tackling the problem.
Thank you so much. It looks like that is the only question that we have. But Dr. In, your presentation was awesome. I hope everyone learned something today about healthcare disparities. And now I'm going to prepare to turn it over to our next presenter.
Great.
Thank you so much.
Thank you.
Next up, we have Melinda Ross, and she is with Massive Bio. And just a little bit about Melinda. She is Director of Provider Engagement, and she's worked in healthcare for over 20 years, and specifically in oncology for 15 years. It is her passion to ensure patients receive the best resources to make educated decisions for their healthcare and treatment. And at Massive Bio, she is enthusiastic to help patients find their way to clinical trials. So Melinda's goal is to help connect the dots for physicians and patients to access clinical trials. And so Melinda, at this time, I'm going to give you control of the mouse, and then you will be able to click through your presentation. Let me know when you've got it. And I think we need to unmute your audio. We can't quite hear you yet. I think you're joining by phone and you might be muted. Not yet. Hold on, let me see. Nope, not yet. It says you're self-muted on the cell phone. Okay. One fix may be to dial in again and just see. Oh, wait. Is that working? Let me hear you speak.
Am I there?
Yep, you're there yet. Perfect. See, technology.
Oh, perfect. I don't know if it's coming through the computer or the phone, so I'll leave it at this. But thank you, everyone, for sticking around to hear the final presentation. And Dr. Ilson and Dr. Yin, I think, did a fabulous job and hopefully helped to provide you with some information on why clinical trials are important. And also, I was really passionate to hear Dr. Yin and how people do struggle to get into clinical trials. Brittany, I don't have control of the screen, so if you just want to go to my first slide or second slide, that would be great. One of the things that Massive Bio does is to support patients. Our mission is that we believe every patient, regardless of where they live or their financial outcome, deserves access to clinical trials. And I, like Brittany said, I am very passionate to be here and to support patients in that. Brittany, are you able to change my slide?
Yes, can you see it?
No, I don't, but if you change them, that's okay. We'll go from there. Well, I have mine here, so I'm just going to go to our highlights. Like I said, Massive Bio, we are an AI company, and we have an expertise in medical oncology and malignant hematology. So we do support any patient with a cancer diagnosis. We use AI technology. It's endorsed and utilized by the NCI for screening and matching patients at any part of their journey. It's a free resource to support you, the patient, and your physician to identify and match you to clinical trials. The service that we offer we use medical records, so you will see that with our service where we're different is if your cancer center does not have clinical trials available, we can find you a clinical trial anywhere in the world. We will work with you based on your preferences. We support you to know before you go. We find that a lot of patients are doing unnecessarily travel. They're finding other academic facilities or centers that they think may have a clinical trial for them, only to go there and find out that they are not eligible for that clinical trial. So we support patients in that, where we will match, we will review your records, we will work with you to understand where you're willing to travel, where you're able to travel, and if you are indeed eligible for a trial. So you have everything you need before you go and make an appointment at another facility outside of from where you're treating. We offer ongoing support and a concierge service to answer your questions and assist with enrollment. We've helped nearly 70,000 patients at this point in time, and this saves time. So it's very complicated on the patient end and even sometimes on the physician end to find clinical trials for their patients outside. Clinicaltrials.gov can be very overwhelming and not always easy to understand. There's over 13,000 trials on clinicaltrials.gov. So if we go to slide 4, Brittany, this talks a little bit about how our services work. You can see here who is eligible. As I said earlier, we support any patient with a cancer diagnosis, and that includes a newly diagnosed. I don't know that either of the previous physicians spoke about this, but oftentimes patients are diagnosed. It's a very scary and overwhelming time. They go to their oncologist. Clinical trials never even is mentioned. There are many clinical trials that are out there that are for patients who've yet to start treatment. So it's our goal and our mission to support patients at every stage of their cancer disease, from the time of their diagnosis to perhaps that time your disease progresses, advanced cancers. Do you have a biomarker? Dr. Ilson talked about this a lot, the importance of NGS testing and finding out what biomarkers you have to see if there is other treatment options out there for you. If you're with a physician who does not do NGS testing and test your biomarkers, we can support with that. We actually support patients to work with labs that specialize in testing for biomarkers. We can write that order for you and be sure that you get that testing that you need to see which trials are relevant and a possible option for your care. And then that really kind of goes in that same box. So patients who don't want the standard of care, are you looking for something more? Are you looking for something novel? We can support you with that and finding what those options are. So once you get to Massive Bio, we have a clinical team that will work with you to gather your records. We will analyze your records and pull out relevant information to match you with a clinical trial. We use, as I said earlier, an AI technology, which is an artificial intelligence. It's a platform that uses 170 data points and algorithms to find the best trial for you. So when we provide you with a report, this report shows you only trials that you're eligible for or you're potentially eligible for once you have additional testing done. The report is generated pretty quickly once we have your records. It can actually be completed within seconds. However, once we have your records, it usually takes about 48 hours for us to provide you with the report. You're then able to take that report and connect with your treating oncologist to discuss those options with you. So when you get to your current oncologist, you can have a high-level conversation with your provider, letting them know, this is why I'm interested in this trial. Is it an immunotherapy? Is it a chemotherapy? and you can plan ahead. So even if you're currently on treatment and you're not feeling great about the treatment, or you feel you may be progressing, we can, again, screen patients at any time. We then have a concierge trial enrollment program. So we are here to support you along the way. Once we provide you with that report, if you're interested in any of those given trials that you are eligible for, we'll work with you to get you scheduled at the trial site. We'll work with you to make sure your records are received there. If you need additional testing, we will also support you with income barriers. Dr. Yin had mentioned travel barriers, financial barriers. Whatever that is to you, each patient is unique, each situation is unique, and we will support you to plug you into the right programs that will help you to get the care and the treatment that you need. We will, of course, on your behalf as well, communicate with your current treating physician. So at the end of your trial, you can choose to go back to your original oncologist. The next slide here shows a sample of what the report looks like. So we will provide you with a report that will highlight who your patient advocate is, your case manager. It will have all your contact information to our services. It will show you a map of where you are eligible for trials at, and then it will have a list. This is just a sample here, so it shows one trial, but the report will have the NCT number on it, which is linked to clinicaltrials.gov, so you can see complete information on that trial. And then it will have a little note here on exactly where the trial is, how far it is from you, and details on that trial. It will also suggest if you need additional testing done, what that testing is. And again, we will work with you and your physician to order the proper testing so that you can get that done in a timely fashion. If you go to the next slide, this talks here a little bit about how to get started. You'll see here that we are partnered with Debbie's Dream. So the QR code there on the right-hand side of the screen will take you right to Debbie's Dream's website, and it will have a form there where you can connect with us. And if you have your phone with you, you can go ahead and scan that QR code. Essentially, what will happen once you get connected with Massive Bio, we will have you sign a consent so that we can move forward and work with your practice to collect your medical records. We will have a patient advocate talk to you about the process, and then, as I said, we will provide you with a report. And then finally here, another way to connect with us is you can actually, and this is very popular, easily download our app, and you can access that here from the QR code that's on this last slide. So a lot of people love the app. You can go right on, you can upload your records here, you can connect with us, you can ask us questions, and you can fill out all the necessary information for us to work with you here. It's really a simple process. It's one sometimes that seems too good to be true, but we really do want to make it easy for you. Our founder, her family was affected by cancer, and they did not have the access to clinical trials that they wished for. So this is where Massive Bio came to fruition. We do have an oncologist on staff. He is our chief of medical officer. So we are fully consumed with oncology and ensuring that patients find clinical trials to help them live a better quality of life. So I think that's really it. It's sweet and simple, and I hope to answer some questions that you have.
Thank you so much, Melinda. That was an excellent presentation. It looks like we have one question, but you might have already answered it. Actually, nope, let's see. What if somebody just asked, I've been doing my own research, finding matching clinical trials. Many are in other countries. I would be interested in finding out more about these trials, but the thought of travel and language barrier can be a holdback. How can you assist with these out-of-country types of trials?
Can you repeat that last part, Brittany? I'm sorry.
How can Massive Bio assist with these type of trials, like with with traveling to other
Understand.
countries, language barrier, that could be a holdback for patients when they find trials outside of the country.
Yes. So we are connected with investigators for the trials. We are connected in actually 12 different countries, so we may be able to offer support. We cannot always guarantee when and where we can offer support. Sometimes we are connected with the actual sponsors of the trials. So depending on what the trial is, we will go ahead and do our best to go above and beyond to remove those barriers. So if you have more questions about that, I would highly suggest that, I think it's great that you've been doing your own research. We can search for clinical trials globally. So if there are specific trials you're interested in, if you go ahead and download, like I said, our app, you can connect with one of our representatives who can walk you through that process. Once we do identify and confirm that you're eligible for those trials, at that time we would be able to let you know how we can support and what options are available to remove those barriers.
Thank you. And also Lisa asked, what is the cost of this service?
So our service is absolutely free. Again, we want to be able to provide patients that access and the freedom to choose, which treatment options are right for them. So we work very similar to advocacy groups across the world to provide patients a free service.
Excellent. I think that is our last question. Someone also wanted us to repeat the name of the app. I believe it's Massive Bio.
Yeah, so if you can go back one slide, you can kind of show them there, but there's that there you go. So if you go to the App Store, you can, it's just Massive Bio, you can search. There is when you download it, there is a physician option and a patient option. Please go ahead and make sure you when you download it, that you register as a patient and not a physician unless you are, so that we can collect the right information for you. The difference in those platforms is really so that a physician could refer their patient. And if you download that, you won't have that same access to refer yourself. So we want to be sure that you select a patient. Even if you're a caregiver and you're looking for clinical trials for a loved one, please be sure to go ahead and select patient.
Thank you. Well, I believe that is the last question. Thank you so much, Melinda. We really
My pleasure. Thank you for having me.
We appreciate you so much. And at this time, I'd like to thank our panelists, all of our panelists from today, Dr. Ilson, Dr. In, and Melinda, for participating in today's presentation. I'd also like to thank our sponsors and all of today's attendees. We appreciate you taking time out of your schedule to learn this really important information. Please be sure to visit our website to learn about some of our upcoming events and programs. As you see listed here, we have a really packed end of the year program, as you can see. So please visit our website to learn more about that. And that concludes today's presentation. Thank you so much for joining us, and please enjoy the rest of your day.